I've been asked to talk about cervical PSOs for chin-on-chest kyphotic deformity, and these are very powerful operations with the ability to significantly correct deformity. What was that line from Spider-Man? With great power comes great responsibility, right? So they carry significant risk, and so we need to be careful when indicating and doing these procedures. So what are the indications for a cervical PSO? Well, number one, it should be a severe fused kyphotic deformity of the cervical spine. And it should be severe because PSO has the potential for significant morbidity. So if they don't have a severe problem to start with, then I would argue probably the juice is not worth the squeeze. Often these are big surgeries that are done in sometimes frail, compromised hosts. So in that regard, this is a classic paper by Ed Simmons and his son, Ed Simmons Jr., entitled 36 Years of Experience of Cervical Extension, Osteotomy, and Ankylosing Spondylitis. And they had a large number of patients, 131 with 2-year follow-up. And just to be clear, these were not PSOs, but they were 3-column osteotomies. And what they did is a posterior column osteotomy with an anterior osteoclasis. So basically, the technique involved a wide laminectomy, total facetectomy, and then the surgeon would grab the halo and crack the head back and basically get an anterior osteoclasis. So what you can see mechanically when you do this operation is that the posterior column shortens, which is generally good for neurologic preservation, but the anterior column lengthens, right? It kind of fish mouths open. So that can potentially have consequences on lengthening some of the soft tissue structures in the anterior part of the neck, like the esophagus, blood vessels, etc. So this is from the paper. He did them awake under local anesthesia so that you could have, kind of the best quality neuromonitoring, right? This was before the days of reliable neuromonitoring. He would sit them in a dental chair. As I mentioned, the wide laminectomy and facetectomy and foraminotomies of the exiting root. And then I love the description. The surgeon grasps the halo securely and brings the neck gradually into an extended position posteriorly as osteoclasis occurs anteriorly. And an audible snap and sensation of osteoclasis are usually noted. So there was no internal fixation. All these patients were treated in a halo for 4 months. Sounds like fun, right? And then a SOMI after that for 2 months. So 6 months of fairly cumbersome external immobilization. It's very old school, obviously, but you could see he had some very impressive results clinically. And if you look at the data, you can get about 50 to 60 degrees of correction in their series. You actually get a lot more correction from this than you do from a PSO because you're just fish-mouthing open the anterior column. And then neurologically, there were some interesting things that they noted. There was one patient who had intraop paraplegia, but they thought it was due to the dura buckling so much that it was compressing the cord, so they did duroplasty and it actually resolved. One patient became paraplegic and couldn't walk. One patient had hemiplegia due to a carotid artery distraction injury resulting in a stroke. So again, that relates to that lengthening of the anterior soft tissue structures. And 18 patients had a transient C8 radiculopathy. And that's probably the most common neurologic complication that you'll see with a cervical PSO. And by the way, there were 4 deaths as well, 3%. If you look at the modern PSO literature more broadly, and the neurologic complication rate. The studies are hard to compare. They're kind of all over the place. But if you kind of average it out, there's probably about a 25% rate of neurologic complications post-op after a cervical PSO. Thankfully, most of these are transient C8 palsies rather than being like a spinal cord injury. But if you imagine, not having C8 function, that has a big effect on the ability for you to use your hand. If you look at other series of adult cervical deformity, not necessarily osteotomies, but patient with cervical deformity, like this one of 78 patients, they found an overall early complication rate of 44%. And 28% of these patients had at least one minor complication, 24% had one major, and 1.3% risk of death. So the deformity should be severe, but in addition, it should also be fused. And my general rule for any kind of deformity correction, whether it be thoracolumbar or cervical, is that if there are available non-fused motion segments, generally it's a good idea to use them to gain correction. In other words, just because you know that a PSO can get you 35 degrees and the patient needs 30 degrees, doesn't mean that's the operation you should go to, obviously, right off the bat. So here's an example of a case like that. 53-year-old man. He had a chin-on-chest deformity, and he also had myelopathy. And this was a case of a dropped head syndrome due to idiopathic neck extensor myopathy. And if you look, he has open, unfused disc spaces. The deformity is pretty rigid, but it's not fused. And so you can exploit those open disc segments through a multi-level ACDF and then a posterior fusion. And this is what the guy looked like postoperatively without doing any kind of osteotomies. So in terms of the technique for a PSO, basically what you do in the first part is a very wide laminectomy of the level that you're going to do the osteotomy as well as above and below. Then you take out the facet joints above and below the level of the osteotomy. At that point, you then enter into the vertebral body and remove about the posterior 2/3 of the body. Once you've done that, take out the pedicles, dissect the plane between the dura and the posterior vertebral body wall and implode that in away from the dura. And then the final step is to take a wedge out of the lateral cortical margins of the vertebral body. And then at that point, you can add a corrective force, either extension through the neck or through instrumentation, and get osteotomy closure. So you can see with a PSO in comparison to the other osteotomy that I showed you, the posterior column shortens like it did there, but the anterior column remains unchanged. And so this is inherently a little bit more biomechanically stable than a Smith-Peterson type or a posterior column osteotomy with anterior osteoclasis. And in general, the literature suggests you can get around 30 to 35, 40 degrees of correction per level. So here are some cases. This is a patient that was 63 years old. He came to me after 15 previous cervical spine operations, if you can believe that or not. And he was fused solid in kyphosis from C1 to C7. And I did a C7 PSO and got him like this. And actually, intraoperatively, we got him a little bit better, but every time I extended him a little bit more, the signals got a little bit iffy, so this is what we accepted. And you can see on the post-op CT scan, that's the C7. C7 is right here. There was this very large anterior cortical thickening in this patient already, which was very helpful because that's sort of the strut that keeps the anterior column from collapsing as you do the deformity correction. So the question often comes up as to what level should you do the PSO, and classically it was done at C7 because there's typically no vertebral artery at C7, although maybe 5 to 10% of people do have one at C7, so you need to watch out for that. But C7 is also an intrinsically mobile area, and it's a small vertebral artery body. And so when you do the osteotomy, there's less kind of work you have to do because you're working on a smaller piece of bone. The downside, though, as we mentioned, though, is that C8 palsy is common, and this is probably related to tension and drift back. And about 30% of patients develop some sort of hand weakness, at least transiently. So the alternative is to do the osteotomy in the upper thoracic spine. And if you want to try to avoid any effect on hand function, you might decide to do it at T2. The other benefit of upper thoracic is that the vertebrae are taller, right? So if you have a taller vertebra and you take a wedge out of it, geometrically you're going to get more correction than out of a shorter vertebra. And you're going to also have good pedicle screws above and below. So it's more secure fixation across the osteotomy. You can use those screws for deformity correction as well. But the downside is that you have to take out the rib. It's more work. It's a bigger vertebrae. Intrinsically, this is a less flexible area of the body, and it may be far from the apex of the deformity. So if you have a cervical deformity and you do something in the upper thoracic spine, you also have to probably carry the instrumentation down even further as well. So like everything, there's trade-offs. But here's an example of a PSO that was done at an alternative level. And sometimes you have to just kind of do what seems to make sense. So 68-year-old woman who was sent to me after multiple anterior-posterior surgeries done elsewhere. She had myeloradiculopathy, and her other chief complaint was that she had trouble holding her head up. And if you examine her, her chin wasn't completely on her chest, but it was pretty close. I called it chin near chest. It was a very stiff, non-reducible kyphosis, but she had a normal neurologic exam. The MRI showed residual cord compression at C3-4 and a spondylolisthesis at T1, T2 with severe bilateral foraminal stenosis. And the patient described sort of what she called electric shocks down her arm, which I thought was related to the foraminal stenosis. And on the axial cuts, you can see there's residual cord compression at C3-4. It's moderately tight at C6-7, and at T1, T2, where there's the severe, where there was spondylolisthesis, there's severe cord compression. On the CAT scan, really bad C1-2 arthritis on the right side. You can see here that the patient had residual OPLL, so I suspect the treating surgeon probably didn't recognize this pre-op, got in there and saw all this stuff and just put the cage in and called it a day. But fairly significant residual OPLL, and she's solidly fused from C3 down to C6. So what would you do in a situation like this? Well, one option was to think about doing a 2-level revision corpectomy through the OPLL. I thought about it, but it could get a little messy. It's a revision, pretty bad OPLL. And of course, by itself, doing that wouldn't treat the deformity, right? It may treat some of the neurologic symptoms, but you still got stuff going on at T1, T2, and the overall chin near chest type presentation. So what I did instead was a T1 pedicle subtraction osteotomy combined with a revision laminectomy at the upper cervical levels. And the idea was that by correcting the alignment, you can get some indirect ventral decompression at that C3-4 level away from the OPLL, and at the same time directly relieve the compression that was there at T1, T2. So this is the postoperative scan. You can see the wedge that's been created at T1, about 32 degrees. Again, you're typically going to get around 30 to 40 degrees. And in terms of her outcomes, she did very well. Her preoperative neck and arm pain was completely gone. Her myelopathy improved significantly, and you can see her cervical sagittal balance is much better. Her chin is now way off of her chest. And interestingly, you can see how even the thoracic and lumbar spine changes as a result of that compression. So this is something that we can do in the lab today as well, and so I look forward to working on that with you guys. Thank you.
Any questions for Rhee?
How many levels down did you fuse from the PSO?
On that case? I think I fused 3 levels down, but the part, I didn't have time to go over all of this, but she had thoracic autofusions. So I love seeing that, because then you know you're not going to get PJK or DJK, because it's got like a nice transition zone. So in any kind of deformity, if you can park your fusion next to an area that's auto-fused, hopefully a couple levels that have been auto-fused, it's like a nice smooth transition zone, and I see a lot less PJK and failure in those kind of cases.
I know the CT and MRI are going to tell you about CT in terms of what levels are fused or not, but have you ever had a patient that once you put them on the table, they go to sleep by anesthesia, you see that they actually can relax and they get much more extension and they're not fixed kyphotically? Has that ever changed your plan when you see that right before starting?
Yeah, I mean, usually though with PSOs, you're going to do it in people who are fused, right? Where a good part of the spine is already fused and you can't get enough correction through the available motion segments above or below. To get a better assessment of general flexibility in the average deformity patient who may not be fused, I actually find that comparing the upright images to the MRI or the CT scan is more helpful than getting flexion extension. Eyes up and eyes down, for the the flexion extension, but when they lay down for the MRI for like an hour, you see what the true flexibility is. So it brings up a really good point. When you order MRI scans on people like this, tell them not to put like a big bump under their head, assuming that it's not fully fused. If it's fused, then it's not going to matter.